Good afternoon. I'd like to call this meeting to order. Welcome to the Assembly Budget Subcommittee number 1 on Health and Human Services. This afternoon, our topic is on issues related to seniors and aging. As you can see, right now we're a committee of 1, and that is because the legislative session just ended today in honor of, Women's History Month. The Assembly did recognize a Woman of the Year for every Assembly district. So we anticipate that shortly the members will be here shortly. But in the interest of time, and so that we can get on to the discussion, we will begin. I'd like to call the members of our first panel forward, and then we will begin the discussion. Sarah Steenhausen from the SCAN Foundation, Amber Cutler, Justice and Aging, Denise Likar from Independence at Home, a division of SCAN Health Plan, Deborah Doctor from Disability Rights California, and Marie Cantwell, the Chief Deputy Director for Healthcare Programs, and Ed Long from the California Department of Aging.
Apparently I walk up faster. They look scared. See, you weren't getting to be outside for too long.
I wanted to see from somebody.
This is in order.
I can do that.
When you are ready, please
Okay,
begin.
great.
Thank you.
Good afternoon, Mr. Chair and members. Thank you for the opportunity to be here today. My name is Sarah Steenhausen, and I'm with the SCAN Foundation. I'm here to provide a very high-level overview of the Coordinated Care Initiative and some background information. As context, it's important to understand the relationship between the Medicare program and the Medi-Cal program in understanding the Coordinated Care Initiative. The Medicare program, as you are aware, is the federally funded health care program for individuals who are age 65 and older, as well as individuals who are under the age of 65 but qualify based on a disability. In contrast, the Medi-Cal program is California's Medicaid program that provides health insurance for low-income individuals, including seniors and people with disabilities. The term dual eligible refers to individuals who are eligible for both Medicare and Medi-Cal, and you have a handout that was distributed by the sergeants that illustrates that Medi-Cal is the wraparound payer for the Medicare program. So to this extent, Medicare covers hospital and medical care services, and then the Medi-Cal program covers the co-insurance and the wraparound services that are not covered by Medicare. And it's important to note that Medicare does not pay for long-term care services. These are the services that are needed for an extended period of time. So in that instance, people who are eligible for both Medicare and Medi-Cal have their long-term care covered by Medi-Cal. What this has all led to is tremendous fragmentation in the system across both the Medicare and the Medi-Cal programs. So you have multiple payers, even outside of Medi-Cal and Medicare, that are covering long-term services and supports. And for the consumers, it's very difficult to access services in a coordinated fashion. It leads to inefficient delivery of services and increases likelihood of unnecessary institutionalization and hospitalization. It's these problems that had led to the establishment of the Coordinated Care Initiative, which was enacted through the Budget Act of 2012. It was an effort to integrate services across the medical care and long-term services and supports continuum in an effort to reduce costs and improve the delivery of services. It's important to note that the CCI impacts 7 counties in California that I have listed in the handout, and there are 2 populations in the CCI that are impacted. First is the dual eligible population that I mentioned, those individuals eligible for Medi-Cal and Medicare. The second population that's impacted are seniors and people with disabilities who are on Medi-Cal only and not eligible for Medicare. So those are the two populations impacted by the CCI. There are three main components to the Coordinated Care Initiative. The first component is a voluntary program for dual eligible individuals that is a federal and state demonstration called the Cal MediConnect program. The Cal MediConnect program is designed to integrate services across both the Medicare and the Medi-Cal continuum and integrate the financing and service delivery. But again, this is voluntary for dual eligible individuals. The second component of the Coordinated Care Initiative mandated that dual eligible individuals enroll into Medi-Cal managed care. In all other counties of California, dual eligible individuals do not have to enroll in Medi-Cal managed care. So while they are required to enroll in Medi-Cal managed care for their Medi-Cal services, they are not required to enroll in the Cal MediConnect program for their Medicare services. So ultimately what this means is if you're a dual eligible individual, you have to enroll in Medi-Cal managed care, but you can get your Medicare elsewhere or through a Cal MediConnect program, okay? The third component to the Coordinated Care Initiative entails adding new benefits to the Medi-Cal managed care delivery system. This is called Managed Long-Term Services and Supports. Previously, in all other counties of California, with some caveats, the state is the contracts for the delivery of long-term care services. But under the CCI, the managed care health plans are responsible for the delivery of specified long-term services and supports, which will be discussed today, including in-home supportive services, community-based adult services, the multipurpose senior services program, and long-term nursing home stay. So again, I've reviewed with you the three components of the Coordinated Care Initiative, but I think, again, what's important to recognize is that it represents a new way of delivering services by integrating services through Medi-Cal managed care in these 7 CCI counties. It gives dual eligibles additional options for their coverage and choices to make, but it mandates that both dual eligibles and seniors and people with disabilities who are on Medi-Cal enroll into Medi-Cal managed care. So in closing, it's important to recognize that I've presented to you the high-level components of the Coordinated Care Initiative, but there are many nuances and issues that you will hear about from the following witnesses, and I'm happy to answer any questions you have.
Excellent overview. Thank you for your brevity, and we look forward to the Q&A and further discussion. Ms. Cutler?
Thank you. Thank you for having me today to discuss the implementation of the Coordinated Care Initiative. My name is Amber Cutler. I am a senior staff attorney with Justice and Aging, formerly the National Senior Citizens Law Center. As you just heard, the Coordinated Care Initiative is an incredibly complex program impacting seniors and persons with disabilities and changing the delivery of their health care. Since the governor's announcement that the CCI possibly could terminate if savings aren't realized, the discussion of the CCI has focused now predominantly on increasing enrollment into Cal MediConnect plans, rather than focusing on the oversight of the program and how well the program is rolling out and performing. Implementation of the Coordinated Care Initiative has been difficult. We at Justice and Aging have tracked the issues of implementation through what we call a CCI fix list. We just recently, today, we released a new version of that CCI fix list where we documented over 50 systemic issues with the rollout of the CCI. Those ranged from wrong populations getting wrong notices, to individuals being enrolled who should not have been enrolled, to individuals who are not afforded the choice, and many more issues. Many of the issues in the CCI fix list, though, were foreseeable and thus preventable. But at the time, the focus was on pushing forward with the CCI despite not having systems ready, which led to thousands of beneficiaries having their first interaction with the CCI program as one of disruption and one of confusion. So I think today the state and the health plans are presented with an opportunity because of the high opt-out rate and the low enrollment rate to really focus on the quality of the program. Rather than focusing, as they are today, on increasing enrollment, they can be focusing on how can we look at this program and make sure that it is operating well. Because if it's operating well, that means people are going to enroll organically and naturally, rather than having to come up with different schemes to have them enroll after they've already undergone a passive enrollment scheme. We at Justice and Aging, we take no position on enrollment numbers. Rather, we want to ensure that seniors and persons with disabilities are enrolled in a healthcare delivery system that works. So what do we need to make sure that this healthcare program, the CCI and all of its components are actually working? And I think the primary thing we need is data. Right now, we don't have any data of whether the health plans are performing and meeting the goals of the program. Are there increased referrals to the long-term services and supports, like the IHSS program, the MSSP program, and CBAS? Are members getting the increased care coordination that they're supposed to be getting under this new program? And ultimately, are we rebalancing the provision of services from delivering them in institutions and hospitals to home and community-based settings? This is the type of data we need, and we need it in real time. The other part of the CCI, which Sarah mentioned, is the fact that many dual eligibles, particularly with such a high opt-out rate, are in Medi-Cal managed care plans only that are responsible for delivering their long-term services and supports. We have no data on how the health plans are performing in that area, and there's no evaluation plan in place at this point to determine whether those health plans are actually delivering better services for those members. So I ask of you that the health plans be asked to provide data in real time so that they can be held accountable. Because if the health plans do in fact perform well, then we're going to see increased enrollment in the plans because members will be attracted to health plans that are offering a good product. Secondly, I think the state and the health plans need to focus on ensuring that policies are in place that protect consumers. Most notably, there are a number of policies that are in place that actually encourage disenrollment and actually encourage disenrollment. So we don't want a policy in place that is going to encourage people to disenroll from the plan or that acts to keep people out of the plan because they're not attracted to it. And one of those policies is the delegation of networks. When you enter a health plan, you're under the assumption that you're going to have access to the entire network of providers that the health plan has. But in reality, what happens is a member enrolls and they're assigned to an IPA or a PPG. And then they are informed that they can only see providers that are within that IPA and PPG. That narrows that network of providers so that the consumer or the member of the health plan can no longer see a provider that, although is in the major health plan's network, is not in their more limited network of an IPA and PPG. So what does that member do? That member disenrolls from the health plan so that they can continue to have their relationship with their provider because they want that ongoing relationship. And because they can disenroll, that's exactly what they're going to do. That's not the type of policy we want in place if we actually want to encourage enrollment into the health plans. There are a number of policies that act that way, and I think that the state and the plan should focus on improving those policies, which in turn would increase enrollment or maintain enrollment. In closing, we believe that the state and health plan should shift their resources that are currently being dedicated to trying to increase enrollment to instead improving the delivery of care and adopting policies that work to improve the experiences of members in the plans. If the program performs well, people will want to enroll. Thank you.
Thank you very much. Ms. Leiker?
Hi, thank you for having me today.
Thank you.
My name is Denise Leiker, and I am here today as the immediate past president of the MSSP Site Association, representing 39 MSSP sites throughout the state of California that we are serving the frailest and most fragile of our senior population. The MSSP beneficiary has been receiving services, had services access across the state for 30 plus years. And to give you a small snapshot of the type of client we're talking about that's being impacted by the CCI enrollment, we're talking about seniors over the age 65 and over who have multiple co-occurring health issues, as well as a lot of social and psychosocial issues. Most of the clients, I believe the CDA has statistics on the average profile is a lone female in her 80s, and her income level is probably only about $800 a month or less, and has little to no social support. Take that with having to deal with and manage multiple medical issues that are impacting her ability to function. Some of those could be cognitive. And so that is kind of the average profile that we see in our program. And before CCI, we've been a quiet little program that's been in the community with nurses and social workers and a full interdisciplinary team with feet on the ground, able to bring together the medical, the psychosocial, and the social aspects that will help them stay at home so that they don't have to go into nursing facilities and they don't have to encounter the healthcare systems with avoidable emergencies through the ERs and hospitalizations. So we've been doing this for 30 years and kind of doing it all. Beauty of our program is we are experts on leveraging community resources for these people, because it isn't just that they need medical interventions to stay in the community. And we have as a resource, we are a payer of last resort when either the medical system fails them or the social system, the resources are not there. For example, we have a small pot of funds that if we've exhausted everything else, but this person needs a refrigerator in order to be able to store their medications and just basic food so that they can eat, we can provide that. We also have the resources when their caregiver quits and leaves them and they're bedbound and they need emergency support. We can bring that in so that it doesn't fall apart for them. So as outlined by my two colleagues previously, MSSP is part of the long-term services and support aspect of CCI. And when envisioned, it was very much presented is that the goal of bringing the LTSS, especially MSSP, into CCI is this is a population, the MSSP population typically has not been in managed care. Quite frankly, they have felt misunderstood and not cared for in the managed care system. So they've stayed in the fee-for-service world where they could get what they need and navigating that system by themselves. So bringing them in was supposed to be a synergy of bringing together the health plans who have no experience in the community like MSSP does on the ground, putting together that world, and bring them together, and while working together, learn from each other and be able to generate data and outcomes that would then inform the next models of care for this frail and very fragile population. So I sit before you today to report out on how our entrance into CCI has happened and to give you some insight into what we need in order to really take care of this segment of the population appropriately. 6 counties have gone live. CCI counties are live, and MSSP is now working with the managed care. Those 6 counties are San Mateo, Los Angeles, Santa Clara, San Diego, Riverside, and San Bernardino. We all have a 19-month transition time clock in those counties. From the moment MSSP became part of the managed care CCI project, we have 19 months from there, that is in statute, in order to get ready for the transition to the program moving fully into managed care, and managed care being responsible for this level of care. So San Mateo was the first county to go, and San Mateo makes their 19-month transition this year. The end of October, the 1st of November would be their final transition. The other 5 counties, we are looking at a April 1, 2016 transition point. But unfortunately, things haven't gone quite as planned. As Ms. Cutler reported, there are a lot of issues encountered in the launch in these counties, and there has been a lot of issues with people really understanding what's happening to them. In addition, for MSSP, we're not a simple program because we're a federal waiver program. So moving us in wasn't just as simple as enrolling people. Actually, enrollment didn't go well, and we have about 25% of our population across those counties that never moved in at all to CCI, and we're trying to untangle that. So we've had a lot of, if you look at a project design, there you first start a project, you got your basic startup period of time. You got to give yourself a period of time to get things together and get things going. And then you start working on your actual working phases, and then you would actually move into your planning from what you learned from all of that into your next model. So here we are, still very much 5 to 6 months in the major counties, dealing with very basic startup issues. We still have contracting issues, we have payment issues, we have enrollment issues still going on. And unfortunately, in those counties, we have not begun to actually do the work of coordinating the care and working hand in hand on for each of these members with the health plans. And we're getting very, very concerned because as the time clock ticks and pressures mount on the state and mount on the sites and the health plans, we have to make a transition in a few months, start putting a transition plan together and start making that transition in a few months with exactly what Ms. Steenhausen said, no data. We don't have data in terms of, because we haven't done the work yet on how the care coordination looks and to inform the next model. We also know that in statute, there is a lot of language about work that should be done to plan that model, that the state is tasked, is tasked with pulling together the stakeholders, pulling together the learning from the project, and being able to create that model of care that is based on the MSSP principles. And so far, the draft plan that the work hasn't commenced, but the draft plan that's forthcoming isn't going to be able to be done, we believe, in a thorough manner, safe manner for a very frail and fragile population in a timely period in order to make sure that they are still going to be cared for in the next phase. All of us have invested a lot of time and energy, and we see the vision. All the MSSP providers have been working with the health plans. There's a weekly state call that happens, but what happens on that call is only problem solving. The agenda is only ever dealing with items of the current enrollment issues. We're still not dealing with the coordination of care. So we are asking the committee to help in planning for a quality project. Rushing on this population especially isn't going to yield a good outcome. Very few MSSP enrollees chose the CalMedi Connect benefit. Most of them stayed with just the managed Medi-Cal. They didn't want to put their Medicare in there because there's no trust. There's no feeling that their needs are going to be met, and they're very scared of that. And for this population, because of the fragileness of the population, they need to be sure. There needs to be stable ground. Additionally, the administration has acknowledged that CCI may not continue. So having a 19-month time clock that would expire before the demonstration is determined to pass and no longer be a demonstration and move to permanency seems a little out of sync to us. So we're here today to ask you to help slow this down. Let's gather the learning. Let's get all of the operational issues solved. Let's get to the actual work phase with everybody working together. Let's see the data, and let's then move towards a very sound, safe transition plan that will take care of this population. I don't think it's the intent of the state that there's no care for this population. We want to get it right. These people need us to get it right. Thank you.
Thank you. And I do want to let you know that one of the members of the MSSP Coalition was honored today as one of the Women of the Year. And because she was on the floor, she cornered me. Explained to me.
You had it right the first time. We know her.
How important these issues are to you. Just wanted you to know that they have been noted.
So you've heard some today.
We heard a little something today. Thank you. Why don't we quickly take the roll? Madam Clerk, would you call the roll, please?
Thurman.
Here.
Bonta.
Here.
Chu. Grove. Jones.
Thank you. Ms. Doctor.
Thank you, Chairman Thurmond, whom I'm delighted to say is my assemblyman, and members of the committee. I'm Deborah Doctor from Disability Rights California. I started referring to the CCI as being full of magical thinking a couple of years ago, and so I guess we're here today to see how well the magic is working out. My particular job is to talk about IHSS in the CCI. There are two streams of IHSS consumers in the CCI. The greatest number of them are the people who are not in the CalMedi Connect, but their IHSS is part of managed care. For those people, nothing has changed, and that's largely giving thanks to the work of previous members of the legislature and legislative staff who wanted to make sure that people on IHSS did not have a negative impact on that program as the CCI started up. So the only other thing I'm going to say about those people is that there are several managed care plans who have made no bones about the fact that they want to get control of IHSS. So I'm sure we'll have discussions as we go along about whether that's a good idea or not. But the rest of my testimony will be about the very small number of IHSS recipients in CalMedi Connect. In Los Angeles County, 80% of IHSS consumers either opted out or withdrew. So we have a very small percentage. Also small percentage in other counties, but LA always is the one we seem to mention. One would hope that that small enrollment would lead to an even better chance of excellent services and care, because after all, the plans were supposed to be geared up for a much larger enrollment, and so they have many fewer people to actually take care of. The road to let me back up. One of the main selling points over the couple of years for people with disabilities, IHSS consumers, was that with the CCI, there would be the availability of additional services, additional home and community-based services, including the possibility of more IHSS hours for services that IHSS doesn't itself pay for, or IHSS-like services. So one thing I'd like to discuss today and find out is, has that happened? It seems like an important question. The road to additional IHSS services starts with the health risk assessment. But the latest information we have, which is from last year, shows that the health risk assessments are not being done by the statutory deadlines. Because the information is so dated, we have no idea whether it's still accurate, but it's all we have. It's from last year. The next checkpoint on the way to getting more IHSS services is whatever assessments the plans are using to determine the need. We have no idea. There is a uniform assessment being developed, but it's not in place yet. So really, I have no idea how the plans are assessing whether somebody needs more IHSS, and if they do, whether it's offered to them. So one question is, how many requests have been made by the plans to the counties to increase IHSS hours? We have no information about that. At least we have no official information about that. Because one of the opportunities was for the plans, who are supposed to, after all, really get to know their enrollees, to call the social workers in the counties and say, we think that Mrs. Jones needs some more hours and they could be justified under IHSS. Will you do a reassessment and increase the hours? Has that happened? I have no idea, but the information I'm given by the people who know best say, no, it's not happening. How many IHSS consumers have been offered IHSS-like services paid for by the plans but outside the IHSS system? And I can give you an example of something that comes to mind. IHSS does not pay for reading services for people who are blind or visually impaired, something that has been a problem for all the years of IHSS. So a consumer who's blind gets a notice from the state which they can't read, and that's that. But they can't have their IHSS worker do the reading of their important documents for them. So a plan could say, well, we'd like the consumers who are now our members to be able to actually read and understand the documents we're sending them, and just on the possibility that they're not sending them in accessible formats, we're going to pay for their existing personal care provider to read those documents. So is that happening at all? The California Association of Public Authorities reports that there are no IHSS-like personal care option services being authorized. They also report that they expected greater demand for public authority IHSS registry services, and that hasn't happened. One of the roadblocks identified at the beginning, a long time ago, was that the IHSS payroll system, CMIPS, has no capacity to pay IHSS workers for work that's not authorized by IHSS. The plans, not surprisingly, do not want to put the existing providers on the plan's payroll. You can imagine the ramifications for that. So what is happening? Is anybody getting these services? Are they contracting with agencies for these services? We have no information. Are the IHSS social workers involved in care coordination teams? They're on the list of people who would be involved in them. I'm told in very few cases. Why is that? We have no information. How many enrollees actually have a care coordination team at all? We have no information. It is way past the time when guesswork and speculation are acceptable. There is none of these problems that have been identified that was not identified in advance, not one of them. Now is the time for the administration and the legislature to get up-to-date information which allows all of us to assess whether consumers are getting what was promised in this program, and if they're not, take the appropriate action. Thank you.